All right, good afternoon, everybody. Thank you so much for joining this afternoon's event presented by HIMSS New York State Chapter. My name is Michael Haas. I'll be one of your hosts today. Thank you so much for joining us this afternoon. We have a great panel and presentation for you today. So sit back and relax. We're just going to go through some administrative stuff real quick, and then I'll pass the ball to our moderator, Elise. Just a little bit about the HIMSS chapter. You know, we put on these events quite frequently. We try to keep them tailored to new and current events that are going on to keep our members up to date on the current events and what is going on in the industry. If you would like to join as a member, please take a look at this QR code and you can certainly look to join or reach out to any of our members to learn more. One other thing that we like to preface is that this is a recorded event, so if you have to drop at any time, please know that there will be a recording posted on our YouTube page. We will also be fielding questions throughout the presentation, and there's time at the end for Q&A, so I personally will be monitoring the chat, and if for some reason we do run out of time today, we will make sure to follow up with your questions later on. So without further ado, I'll pass the ball over to Elise, our moderator. Elise, take it away.
Thanks, Michael, and I'm really excited to be here today. We have an expert round of panelists here where we're going to really focus on interoperability for the patient. Now, oftentimes with all the emerging technologies coming down the pipeline and all the initiatives that we're working on, from policy to technology to accessibility to user engagement to interoperability, it's really easy to get set in our ways and focus on what we have to do day in and day out. But we want to use this time to take a step back and remember why we're all doing this, why we're all working on commenting on policy initiatives, on standards, on interoperability initiatives, because we're all doing it at the end of the day for patients. And each of us are patients, and we can each we each have our own story. We each have our own experience navigating the healthcare system. And so we're inviting these panelists to not only share really what they do and how they've worked on advancing interoperability initiatives within their own organization, but also how are they experiencing that as patients? How are we advancing these interoperability initiatives to really positively impact the patient? So with that being said, I want to give you a quick intro where we have Dr. Erin Patterson, who is the Associate Chief Medical Information Officer at Mount Sinai Health System. We have Paul Wilder, who's the Executive Director of Commonwealth Health Alliance. We have Arvind Rao, who is the principal at RSM, and we have Julia Joe, who's the Chief Information Officer at Community Behavioral Health. So I'm going to give them a chance to introduce themselves and describe a little bit about what they do here. So Dr. Patterson, how about you kick us off?
Hi, good afternoon. Thank you for inviting me. Through my work with the Mount Sinai Health System, I'm involved in a lot of our technology deployments, as well as trying to optimize our workflow for our providers, primarily is my area of focus. I'm also a practicing clinician. I have a private practice in psychiatry. My background, I'm double boarded in psychiatry and clinical informatics. And I come about this through the Boonshop Physician Leadership Development Program in my background, which is an integrated MD, MBA. So I've always been very interested in systems, but I like to have the system focus as well as being in the room with the patient. I find that balance is really important to the work we do.
Thanks, Doctor. Paul Wilder.
Hey, good afternoon, everyone. Paul Wilder here. So I'm at Commonwealth Health Alliance, and Commonwealth is a nonprofit 501c6 trade alliance. So primarily made up of large EHRs and small ones and mediums, but mostly EHRs, as well as other health information technology companies with a common mission to have interoperability nationwide. So a little different focus than kind of the way the HIEs and regional state things grew up, and we'll talk a little bit about that shortly. So pleasure to be here, and and talk a little bit about how this benefits ourselves as human consumers and patients ourselves. So thank you.
Great, thanks for being here. And fun fact is Paul Wilder used to be my old boss at New York eHealth Collaborative, so it's fun to get back together. Next, how about Arvind Rao?
Hey guys, nice to be here. Nice to talk with you guys this afternoon. My name is Arvind Rao, and I'm based out of the New York, New Jersey area. I'm a principal at RSM and been here probably about 8 to 9 years, primarily focused on working with providers, both from the not-for-profit, for-profit, as well as some state and local governments, essentially helping with technology integrations and pulling systems together and having them talk with each other. So that's the perspective I bring today, not so much from a service provider, but from the standpoint of integration and what technology has to offer. And I'm looking forward to talk with you guys about that.
Thank you. Happy to have you here. And Julia Joe.
Hi, this is Julia. Good afternoon, everybody. So my name is Julia Zhou, Z-H-O-U. So that makes me the original Jay-Z. So joke aside, I have been in technology for 28 years. Pretty much the same years for healthcare as well. So now I take over the Chief Information Officer job in behavioral health. We are the single payer for City of Philadelphia Behavioral Health Medicaid program, and we serve pretty much 40% of Philadelphia's adult population, one of the biggest city, poorest city in New York, in the nation. And we have a significant mission to make this community a better place. And every single year, we're trying our best to provide the best behavioral health to our members and make providers work a lot easier with technology. And nice to meet everybody and looking forward to this discussion.
Thank you so much, Julia. We're really happy to have you here. And again, my name is Elise Kohl-Grant. I'll be your moderator today. I currently work at Amazon Web Services, working with healthcare providers, helping them navigate their cloud journey transformation. Previously, I was the CIO at a behavioral health network system in New York, and I've spent most of my career helping advance interoperability initiatives, but also expanding access to technologies for more vulnerable populations and the providers that serve those more vulnerable populations. So this is a really big passion of mine, and excited to have this panel here. So we're going to just go right into it. And, you know, I think it's important for the audience to have a baseline of what interoperability is and what we have done in the past and where we are today. So, Paul, can you walk us through a short history of interoperability initiatives?
Well, it starts with the dinosaurs, and they became oil. Now for those, actually, we go back probably the 2000s, really. So you saw the emergence of state regional HIE starting to emerge. In fact, New York State kind of founded its effort about 2006 with the founding of New York eHealth Collaborative to set up policy and how this would work. But that was almost too early in the game. EHR adoption was medium-sized in the hospital market, medium to low in the ambulatory space. So what you saw is 2008, 2009, of course, we had a pretty large market correction that led to the stimulus bill, which led to what we call ARA. And ARA funding brought around meaningful use, which was that thing that helped promote EHR adoption, digital technology adoption, but also accelerated interoperability, because part of the idea was first get a record that you can store the digital data in, then add other workflows, including exchanging records between them, because paper records don't exchange that well. You can send mail or fax, but that's nowhere near the scale we are today. Fast forward a little bit further, you get around 2013, Commonwealth was formed. There were some things before that, some predecessors, including eHealth Exchange, which exists today, and some others. But this is the first time industry kind of stepped in and said, "Ooh, we got to do this at scale." Partially it's a kind of an offense-defense strategy. If you don't do something well, then it might get regulated. You might do this the wrong way. So let's do it the right way, prove that it works, and then scale from there. And the main difference being the technology is embedded inside of products, and then the provider practices that join just kind of flip the switch versus it being a direct integration to a state or regional HIE. And after that, we saw care quality and national frameworks emerge, which has led up to TEFCA, which is where we are today, which is kind of a framework connecting the various mature networks that are out there in the market today. So a lot has moved forward. A lot needs to be fixed. A lot to change. But the main difference was we actually all have EHRs now, and it makes it a lot easier to hook up digital things than it is to hook up paper records. And so things have advanced a lot.
Yeah, This is true. I'm going to circle back to that offense defense strategy. But before I do, at what point, so you kind of laid out some very big initiatives and policy advancements to help interoperability. Now, at what point do you think we made the biggest leap forward? Was that meaningful use? Was that like our nuance in TEFCA?
Well, two answers. I think meaningful use accelerated the conversation. I think you can look at it that way and start to establish what policies need to be in place to get this stuff to move. It accelerated looking at HIPAA, the HITECH Act. It kind of bore out a lot of things we have a lot of gaps to fill. It's not just, launch this thing, build it, and they will come. From a volume and accessibility perspective, I don't want to overly tout what we do here, but quite frankly, the merging or connecting of Commonwealth to care quality was the biggest leap in exchange we saw in the country. If you look at marketing slides, it was like I talk about a hockey stick moment where you see a flat line and then something just goes like that. It's early 2019 where you see, things that are 10,000 a month going to 1 million a month. Like it's a multi-factor difference that occurs to the tune now of the Care Quality Framework Exchange. I believe it is about 1 billion transactions every 6 to 7 months, and we're 1 billion about every year. It's almost 9 months as a run rate now. So it's a dramatic difference from a couple 100,000 to a couple billion.
Yeah.
And it's showing no sign of stopping, quite frankly.
Yeah, and just to add to that, just a couple of things on that. I think besides the regulations and other things that have come up, I think there's also that shift in terms of, the patient experience and patient demands for what types of services they require. And, with the heavy amount of funding that's come in, around the 2018, 2019 timeframe, it also changed the landscape of the types of service providers out there that, entered the market, which required a lot of other organizations also to try and think of redoing and restructuring the way they provide services, the way they integrate with other, systems, solutions, and how they could serve their clients in a better way. So that's another part of what, kind of started to get us down that path. And, then with COVID coming into the mix, that also changed the dimension even further in terms of, how do you do a lot more with, your technology in a remote model and be able to provide services in different ways, and, thinking about remote patient monitoring and telehealth. So it kind of spanned a lot of additional types of services which needed to be put in place through technology and integration. So I think that's another part of what kind of really spiked things, and now we're seeing the continued investment in behavioral health organizations, as well as looking at other large organizations like, say, the Microsofts and the Salesforces and others that are getting into the market saying, hey, how can we help integrate systems and technology for you guys so that you could be part of exchanges and be able to exchange data in a more seamless manner.
Yeah, thank you.
Just one quick add. I mean, that's a great point. And I answered kind of the explosion on the provider side, really treatment provider to provider. The explosion, it's a great point. COVID actually did a fantastic job of increasing patient access requests. Turns out when hospitals are closed, it's really hard to get data out of a medical records department that isn't there. So it really did jumpstart how do we get these portals to work? Because quite frankly, we don't want them coming into the hospital either. And there's many reasons why you need your records, disability claims, Medicaid, insurance. And so you had a lot of people either on furlough, out of jobs, trying to figure out how to maintain their livelihood and their health at the same time. And they needed the records to do that. So one of our patient portal applications on Commonwealth saw like a 10-fold increase, the day everything shut down and how many people were going to them to try to get records versus going directly to health systems. So that was a big leap.
Yeah, that's an interesting point, I remember when we were talking about patient portals, a decade ago, and they didn't really kick off like people expected them to do. I don't know if that was associated to the lack of education or technology, but it does seem like the pandemic, like you said, was really a jumpstart into patients managing their care. And do you think that is kind of why we're here now and really thinking about providing better access to patients? Was it the pandemic that really pushed patients to manage care, or did the pandemic really challenge providers to figure out how to manage care differently, or both? And I'll kind of just throw this out to the general panel to see who wants to jump on that.
I have an opinion on everything, but I'll let someone else jump in.
I think pandemic plays significant role in how we're going to access data in what kind of format and where, because I think before pandemic, people get so used to come to office and, get all the information in one place. But after that, during pandemic, the information is extremely important because you don't talk to patient anymore face to face, and all these informations come from this portal or this centralized data hub. So the access to this portal, to this data hub, plays significant role on how we're going to provide services and how we're going to even run business daily by daily basis. So from, I think, behavioral health perspective, over the whole pandemic 2 years, interesting fact is we used to have no-show rate, like face-to-face psychiatry session is about 70% no-show rate. So people schedule, they didn't show up. But during pandemic on telehealth, it's completely reversed. The no-show rate is below 2-digit, it's 9%, and significantly increased the people who really want to use telehealth and really want to use interoperability to transfer all the information and provide health virtually. So this shift that we see in behavioral health is significant.
And Dr. Patterson, I want to pull you into this because you are the front line, right, working with providers. Was it that patient push, that provider push, or kind of that mix of both?
Yeah, I think early on in the pandemic, there were kind of a number of initiatives, but I do think it was instrumental in propelling forward our technologic capabilities. With everybody was all on board, lives mattered. We had to connect people. One of the initiatives that I was running was trying to get iPads into rooms for patients to be able to talk to their family. We couldn't have visitors, and we knew that we had a limited amount of time where patients might be responsive during COVID. And that was so critical. Also thinking about interpreters or people with physical limitations to be able to communicate using more advanced functionality. So we really had to innovate to bring that into play. Fortunately, we had been experimenting with a lot of telehealth products and initiatives beforehand, which sort of made the transition easier because our workforce had some awareness of that. But I do think it really catapulted those efforts forward. But I also think it really highlighted the digital divide, the equity issues to access, right? For some people, we really had to think about getting devices and cables out into the community, right, to charge devices and things like that during the crisis, to make sure that we didn't leave patients behind that didn't have the access to the technology.
Yeah, absolutely. I think during the pandemic, we usually use technology as a tool as opposed as the solution, and that alone kind of uncovered some very clear data points around how folks don't have access to the same technologies that other folks do. Alone, we're changing policies around telehealth, which is really exciting, but then looking at, okay, who has a data plan to actually download the app, and, can they actually spend down those dollars to download the app, and are they forced to do that when they don't have the money to do that, right? Now, going over to Julia, you're in a unique position with your organization in Philadelphia. I'd love to hear some of the things that you focused on to move interoperability forward and provide better services for your patients.
Yeah, so basically interoperability in Philadelphia, even in Pennsylvania right now, is I would say, pretty mature kind of stage. And with that established framework, I think it's extremely important for us to serve over 700,000 behavioral health needs Medicaid patient. So we, since I joined the company 2 years ago. So when I joined the company, I want to establish this framework, how we're going to provide a really good member journey and provider journey to make providers' life easier because of the provide them the information at their fingertips, as well as how we're going to provide a very easy, streamlined member journey to provide accessibility to people who really have behavioral health needs. So all these data, we consolidate them into one place, and with omni-channel approach, and we try to generate this streamlined, like optimized operation type of workflow to give provider as well as a member, to improve their engagement as well as accessibility.
Yeah, thank you. Arvid, I know that you work really closely with providers on this. Can you provide some examples and some of the things you've worked on with providers to kind of propel this forward?
Yeah, and when it comes to some of the work that RSM and my team does, it's kind of all over the place. But when it comes to interoperability and cures and integration, a couple of things that we focus on. One is around helping organizations and be more compliant with, or be compliant with cures. Just as an example, where we would work with them to try and provide direction in terms of have we touched upon all the different types of technologies that need to be compliant. And this is an instance of say a large health system that has probably about 20 different EHRs spread across maybe 30 to 40 different facilities providing different types of services, including behavioral health, including physician clinics and hospitals in different locations across the state. So in those types of instances, we would work with them to try and get some input on, hey, are we touching everything that needs to be touched? What are we doing from a process standpoint? How are we tying in the requirements and making sure that, number one, technology meets those requirements, and then two, what are the processes within the workflows that now start to account for, okay, how do we communicate to our patients, telling them about what is available, what type of data you can get access to, and then looking at some of those risks around when it comes to specific cases like the mother baby kind of scenario, or say in behavioral health, what data can you share? So thinking through all those different aspects of it and helping guide them towards what do we do for compliance, and then if there's a future check in terms of what have you done to be compliant, and especially with large organizations like this, thinking through what kind of checklist items should be there, and how do you say, okay, this is all what I've done. In addition, a couple of other areas that we try to help with, and this is where we're seeing a lot of additional movement, is over the past 3 years, and this is kind of testament to the shift in what organizations are doing in terms of technology, is we're getting a lot more requests from our clients saying, hey, we have reached a certain point with our technology and systems, but we need to scale. We need to be able to gather data from different systems. We need to integrate with remote patient monitoring systems. We need to have like the patient portal and telehealth. And especially in behavioral health, it's always been a little bit, especially with the not-for-profit organizations, it's always been a little bit of a one step behind in terms of the investment in technology. So with the funding coming in, and with the need to survive, just because there's so much more competition, that's another area where we see a lot of organizations saying, hey, how do we get to that next stage? What do we invest in terms of technology? What should our strategy be? And then how do we integrate these systems? So that's where we partnered with a couple of different product vendors to go out and help make that happen.
Yeah. You touched on a lot of great points. One, behavioral health providers have always been a step behind. This is due to lack of funding, lack of resources available. They're always kind of like the second thought. I think that we're sort of getting over that hurdle slowly as we see more providers other than your, MDs being able to be eligible for certain funding. That is coming down the road. Now, another thing you mentioned, right, is compliance. You said that over and over, is compliance is complex. I know I work with healthcare providers all the time where we're helping them map to HIPAA, high trust, NIST, GDPR, right? And mapping those different technical services and sort of those safeguards, right? It's very, very overwhelming for providers. And compliance is, it's a huge burden for providers to try to understand and get through and know that they're actually compliant when they're trying to link their technology department with their quality department, with their service providers, right? And try to get everyone on the same page. And so I know it's really complex, and policies can be open-ended sometimes, and so it's sort of open to interpretation. You mentioned the Cures Act, which is another policy in addition to some of the ones that Paul mentioned earlier on. And I want to kind of talk about that a little bit. And, Dr. Patterson, can you provide some examples? First, actually, can you give us a baseline on the Cures Act and provide some examples of how this is affecting your providers and your patients and your operations?
Yeah, and I just to end up with what was being talked about before, sort of this idea with behavioral health, and this ties into trying to comply with the 21st Century Cures Act, is if you think about New York as an example, we have regulatory bodies for public health, which is different than OMH, the Office of Mental Hygiene, which is different than OASIS for addictions. So addictions, mental health, and public health are siloed. We have to navigate those. My patients have medical problems. They have addictions issues, and we have to try to figure out how to navigate all of that. Where the person is one person, and that in and of itself, from a interoperability standpoint, becomes an issue. We have to restrict certain records to certain places, to certain providers, in order to comply with those laws in a way that can sometimes get in the way of good quality integrated care. You can't even offer, in some cases, integrated care because of the barriers around how some of these are from a regulation standpoint. With 21st Century Cures Act, the idea behind it was that if data is available within our electronic health record that we cannot, and a patient wants to access it, we can't put a block or a barrier in place en masse. It has to be specific to the patient and for a specific situation in which there's the clinician believes there's a high likelihood that the patient accessing that information could contribute to imminent harm to themselves or somebody else. I mean, how that's defined within the regulations, and I'm not a lawyer, but I think, from my understanding of it, when we think about the idea that patients have access to their information right away to make good health decisions, I think we can agree is sort of a common sense thing. For our providers, that means shifting how we document things so that when patients get this information, they can understand it. And it also means, I think, having conversations with patients more upfront, so that when test results start to come back, patients aren't panicking when they get results that they don't necessarily, know how to interpret. I think all providers out there understand that there are tests that are going to come back abnormal on the lab that really have no clinical implication to your health. And so there are some test results where they are going to be abnormal and it's not an emergency. And so from the provider standpoint, we're trying to shift that conversation up front, as well as shifting how we document. Behavioral health, that could be a problem. I don't agree. A lot of psychiatrists don't agree with the personality disorder definitions. They're in debate. They're being reformed. But if you seeing a patient is primarily personality disorder diagnosis, that can come across in a very pejorative way to patients. And so it means having a conversation to sort of say, look, there are criteria here that we've talked about that fit your life. You agree on these things. These are the terms we use diagnostically for reimbursement. They're in debate. That kind of discussion needs to happen with a patient so they don't see that and start Googling and get into trouble. In terms of patients having access and that transparency, the idea is that engagement, but certainly there have been reports from a range of health systems that and even studies that are coming out to show a significant increase in patient messaging as a result of 21st Century Cures Act, that from the time that those results go more, patients are messaging and bombarding providers with more messages about those results. And I think one of the examples that I would give is if we think about HIV testing, HIV testing, your initial, for some of these tests, HIV, syphilis, others, you can have stages of testing. For those that are not necessarily aware of that, when you do an HIV test, you really want to make sure that if that person has HIV, you catch it. So the HIV test tends to be really sensitive, which means there's a risk of having a false positive, of telling somebody they have HIV when they don't. So if you get a positive HIV test result, it's common that that positive test is sent to have a second test done. That second test is much more specific to verify that that positive really is a positive. And based on how that comes out, you could end up sending to a third confirmatory test to make sure you have the right result. Now, do we release the first result to the patient where it could have a high rate of false positives? What does that do to a patient when they see HIV positive? What do they do when they see HIV positive, HIV negative? Then what do you do, right? It doesn't necessarily mean that it's an interpretation. So I think where we're looking to progress is not just dumping data out. I used to talk about it personally, that meaningful use is neither meaningful nor useful to the clinician, because what it meant was I would get a 100-page transfer document with a bunch of garbled data in it. And sure, everything was there, but it wasn't clinically actionable. I think where we want to progress is not just dumping data out, but providing a higher level of data, translating that into, in informatics, we think about data, information, knowledge, and wisdom, right? And we want to help to not just give data, 140/80 numbers, to sort of say information, that's blood pressure, to sort of say, information, that's a high blood pressure. And wisdom is, okay, 140/90 is high, but what's the context? Were you exercising? We should repeat it before we treat it, right? There's stages of information and how we communicate it. And I think that's one of those things that we're facing right now with 21st Century Cures Act. I think we're in that painful phase of trying to move from just data dump to more meaningful information to patients.
I'm going to give the panelists a chance to respond, because I think you said a lot of really, really great things there. Does anyone want to kind of jump off with Dr. Patterson?
Well,
Okay,
go ahead. Go, fire away.
I just want to say, basically, I just want to echo, that's one of our challenge as well, is how we're going to have the data governance in place, right? So the data quality is not the more data, the better is. We need to basically to harvest the right amount of data to make the decision. Sometimes it's not really the more, the better. And we put this data governance framework in place, and that's one of the very first thing I did for CDH, is how we're going to control data quality and control the right amount of data to drive business results. I just want to have a quick echo on that.
Yeah, I mean, just as we're trying to do the patient perspective here, and I entreat everybody to think like one once in a while. All that said, Dr. Patterson, I don't disagree with a big but. I do think that the consultation before the lab result and the like is heterogeneous at best in terms of its quality. There are many times where providers don't have that consultation, and kind of shame on them when I get the result, and now I have more questions because I wasn't prepared for what that thing was actually resulting. Also, I remember talking to a consumer advocate organization in New York that was focused on AIDS patients, and they said very clearly, you're damn straight I want my result the second it arrives, because I may have to do behavior changes immediately that help the community and myself. And I do want to get to my next stage, test 2, stage test 3, and it's not my fault that you're out on vacation that day. So I think there's a flip side here. It's like, sometimes you may have to pick another provider because you have something you really should be acting on right now. And that's just something you got to deal with. Like, the market is going to be more fluid with faster access. The good news is, as a patient, I've observed most providers have gotten out of the way of test result delays. Like, I think if they found that it's, even though they get more messages, it's not worth being in the way. But some haven't quite gotten the message yet, and sometimes it's EHR's fault. My daughter had an example. I needed a thyroid test due to having some panic attack issues. I had a darn tough time getting the result out of the provider who kept saying it hadn't arrived to their EHR yet. My best result was calling the lab company and getting it for them in 3 seconds once I actually called, in this case, LabCorp. So, be sensitive to the fact that speed matters a lot to patients. And it's not just that we're trying to find data, we're trying to engage with our providers and know if we should bother them again. In that case, no, I didn't have to. I knew what the result was.
Yeah, it's interesting, you know, before I had heard that case, I was always like, let the data flow, all the data should go to the patient, but you really have to think about or be sensitive to health literacy and understand that it's, you know, the way we read case notes, the way we read medical information is very different than the way patients read medical information. And I do wonder, right, if you get a positive HIV result on a Friday and the doctor's office is closed, and that result is going to the second lab, but if that's not clear to get tested for a second time, if that's not clear, is that also fair to the patient to now be stuck and their provider doesn't come back until Monday, right? And now they're left with this information that's obviously like life altering. You know, what do we do after that? I'm sure there's like some wraparound services that I know folks in the community are working on, but it's definitely a challenge, and it's a really like case by case scenario. Unfortunately, I don't think that there's like one rule of thumb that we can put on this, and it makes it really complicated.
Yeah. You know, the flip side though of what I just said is I do have some concern, and there's no controls on this actually, and I don't know why this isn't in discussion. On the consumer application side, there's a difference between me seeking the data, hitting the refresh button over and over again, indicating I'm self-selected into being prepared to read this result, and getting a random alert saying something just occurred, right? So if I'm very interested in my HIV test and I'm in my EHR portal hitting refresh, 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 you know, every 5 minutes, probably should get me the data. But if I'm just having, you know, playing golf or out in a movie, whatever, and my phone notification pops up with, hey, you have HIV, that's a bigger problem, right? I wasn't ready. I was in no way prepared for that to happen. And there's no control on when the consumer application
Right.
and when you're going to get the notifications.
I think you're quite right, and I hear your point. I think what I would say is you don't want data, you want a higher level, you want information, you want knowledge, right? You want to know if you click that button and it said your preliminary HIV test your test is pending and it needs confirmation, and many patients have a false positive at this stage. You have a positive, but you shouldn't read into that you have HIV until we have a confirmatory test. Right? If it gave you that information, that would probably be nice, but it doesn't. It just gives you the result. And I think in many cases, though, you could probably come up with a number of examples where getting that result early made a positive difference for the patient. And I would not argue that. I think it's really about. I think in general, we probably all agree that getting the information out there is a good thing. I think it's just really thinking about some of these cases. You know, another one is for many women, sometimes pregnancy does not go to term. Now, do you want to get the pathology results, the descriptions of a fetal demise? Is that useful to you? Do you want that to come to you when you go to check your cholesterol? That's an example, right, of something that would be a pathology report that some people would not want even to see on accident when they're trying to collect their cholesterol. So there are a number of, you know, we have to think about the very invasive things that happen in people's lives medically, whereby that thing can just get thrown in with all the other stuff, you know?
Yeah. That there needs to be some human empathy when thinking about what information we release and provide patients access to. Very, very true. And that kind of goes back to Julia's statement of like data quality, data governance, and then creating that other access piece where what you said, doctor, is kind of turning data into knowledge and wisdom, but in a sensitive fashion that can be easily digested from the patient. And I don't think we're definitely not there yet. I think we're getting closer because we're having these conversations. But, you know, especially when talking about behavioral health, it's hard because there's not a lot of standard pay codes. There's not a lot of standardization. Everything's in the case note. There's Z codes and stuff, but those aren't really widely used. So it's really hard to even start that because I don't think we've reached the hype of actually having access and standardizing and normalizing the data to understand what we're looking at, much less like help the patients fully understand. I want to take these, I want to take this conversation to sort of break down the different layers of users, you could say, of personas. And I actually heard Paul Wilder talk about this and mention the 4 Ps: public health, payers, providers, and patients. And let's break that down a little bit of, how does this, whether it's a Cures Act or other policies, and when we're talking about interoperability and we're talking about data accessibility, what does this mean for, let's start with you, Paul's public health. Let's start the top tier of that. And what are the struggles and the barriers for kind of public health accessing data?
Yeah, thanks for that. First of all, just for the 4 Ps, just the context of that, what we found is whenever you're doing exchange between 2 common Ps, it's generally relatively easy. So patient to patient, they can send their data any way they darn well please. Provider to provider, we have networks that do stuff. Public health agencies coordinate with each other at some level. And payers actually, both market-wise and by regulation, are better at sharing between each other. The second we cross Ps, things get a little dicey. And it's partially trust, it's partially policy. There's many things that happen. And so public health, great example happened, of course, under COVID. What the provider community did, at least from the technology side of the provider community, so Commonwealth Care Quality and others representing vendors who then had customers, was we opened up the networks and said, look, if you want to make requests under treatment, because you're not supposed to, when you take a transactional request, you're supposed to say under what use you're using it for. And we said, our system, we can try and plug public health in right now, but that's not what works. So let's allow the public health departments to come in under treatment, under the wrong use case assertion, to let the data flow. And interesting, what happened is very few public health departments actually took us up on the offer. I think in the end, it wound up being one state. And the reason why was our networks are sending around a very robust set of information, and many public health departments don't have the fiduciary right to all of it. They don't know what to do when they get a CCDA of 2,000 elements, when their rights are 12 things on the top of the fold on a screen that they would be able to get. So they were concerned about accidentally having a honeypot. They didn't, that would be an attack point that they're not well protected for, and many other things. So we found that even when you try and make it really easy, there's quick things that can still make it relatively hard. And this was the provider community trying to do the right thing and saying, yes, we do think this is very important. We do think this should go across state lines. We do think that patients don't necessarily have geographic boundary. Sure, let's do it on a national scale. And we didn't get many to bite because they were concerned about their own use of the data and trusting themselves, quite frankly. And that wasn't a factor we really thought about. That trust is, we often think across entities. And sometimes you go, wait, do I trust myself with this data? No, not yet. So I think the movement towards FHIR actually is likely to help this dramatically. FHIR versus today, most of the exchange going on at scale is document-based, large, monolithic things with a whole bunch of data, and you're looking for one atomic piece on page 7, line 3. And public health under FHIR would be able to request just the data elements, one they have the right to, and 2 that they know how to control and use. So it allows them to more atomically get just what they need, and not all this extra stuff that they're going to throw away or accidentally discard. So I think that's a big jump that's coming. And we've talked about FHIR for 10 years now, but this is really a 6 to 18 month flip about to happen. I've said this many times, but I'm willing to bet in 2 years there'll be a significant FHIR movement compared to everything we've done the last decade.
Interesting. Going down to kind of the second layer, payers, Julia, can you kind of insight us on what's going on?
Payer is very interesting, I will say, position in the whole interoperability, because payer has this tradition, the culture for payer is how we're going to cut down the admin cost and increase the utilization, right? So we try to make money, some of the margin, and everything else is all business driven. So interoperability comes out, as Paul rightly said, is we have a lot of compliance requirements, the framework, and you have to basically obey all these regulations that comes with it. And, interoperability becomes very expensive for payer, whether we really want to, put all our money into investment into this just to follow the rules and get this in place. place just said, we have the check mark, or we want to really make a difference. So a lot of times payer kind of like hesitant on the overall strategy on the interoperability based on how they operate. So that's basically the biggest challenge, and comes down to, I would say, payer, especially behavioral health payer, is our provider group not only facing the general provider type of challenge, but our provider is very not quite tech savvy. So it's really hard to ask our provider to have certain kind of standard, how to exchange data, how to get all the information into one platform, and all these rules, and on top of their extremely busy schedule, already kind of burnout situation. So those are the fact that really for us to try to juggle all these challenges and try to make providers' life a little bit easier. And for our behavioral health member, on the other hand, we reach out to a lot of homeless people, and a lot of homeless people, gather data is already a challenge, right? So all these data information, sometimes they either don't want to share, don't want to tell, or don't remember. So a lot of, interoperability for members, especially behavioral health members, the data sets, even get the data sets to share with other parties is a challenge for a behavioral health payer like us.
Yeah, no, thank you. And you really kind of touched on even more layers here and created a nice avenue for Arvind to kind of talk about the provider's perspective and, what are some of the barriers, what are some of the struggles, even the initiative that like you're seeing going on.
Yeah, in fact, a lot of what Julia, spoke about in terms of the technology challenges, we're seeing quite a bit of that within the behavioral health space, especially with the slightly smaller organizations within the 50 to 100, 150 million range of revenue. These are the guys that are really struggling with technology in the first place. I think the first types of challenges that they want to deal with and address is, like Julia said, how do we do more with less with what we have right now? We're trying to get through some of the basics, where we don't have technology for, say, a patient portal for authorizations from a remote standpoint. We don't have, telehealth. And let's think about getting to those points first and integrating within our own organization with the different types of products that they're using. And then think about the next step, which is more about, interoperability and like external, connectivity. Simple example of this was just a couple of weeks ago, we were with one of the providers that we were working with that are looking to move to a different technology from the EHR standpoint and trying to figure out what are those requirements, what's important. And I think a heavy amount of focus was on some of those basics, and then the things about, okay, are we thinking about connectivity with exchanges? Are we thinking about other compliance needs there? And while they know that those things are important, I think they end up looking at those as a step two. So that's one of the initial hurdles that we've heard about and see quite a lot of. And then the other part of it is for the once we start to go down the path of interoperability and connectivity between when we look at social determinants of health and trying to bring in data from different organizations or other service providers. A big part of that is, hey, yeah, we need that data and we think it's important, but then, thinking about going back to the governance part of it, how are we going to actually use this and bring it into our workflows where, it's meaningful in terms of what we do with it. And I think those are the other challenges that some organizations are facing in terms of technology is there. You figure out the first hurdle. The second hurdle is how do we use it and how do we make it useful? And then how do we do it in a secure and compliant manner? That's the other thing that a lot of providers struggle with in terms of, hey, if I'm sending my data out or bringing data in, what do I trust? And, one organization's methods of verifying information may be a little bit different from what we've got. So I think just going through those barriers also is another really interesting and challenging thing that we hear about a lot.
Yeah. You mentioned making the data useful, right? And I think that's looking at it even though this is interoperability for the patient, it's also looking at it, how can we make the data useful for each of those layers, public health, payers, providers, patients. We don't need access to the same data, the exact same data, but what's the story that we're telling with the data for those end users, right, to make it actually useful. And, you know, Dr. Patterson, if you want to speak on the patient perspective, I know that you provided some really interesting use cases on pregnancy and AIDS. Where I want to kind of like change it a little bit is, where have we seen this be useful for patients? If I can challenge you to find, you know, use case from the patient perspective for that part.
Well, to Paul's point earlier, in the vast majority of cases, it is useful, right? I'm highlighting some of those challenges that we have to be mindful for the audience, for people that are trying to do this work. But I do think, you know, we are seeing, because of the investments in interoperability, the opportunity to do some really great things for patients. One of which, at the Mount Sinai Health System, as an example, is you can go to any of our facilities and give your chosen name, be registered by your chosen name, and link that to your legal identification. For some patients, for transgender patients, for example, who might be transitioning, they may have a chosen name, but have not yet been able to transition or felt safe to transition to change their legal name. And that disparity can become a real problem. It also highlights the challenges of legacy systems, right? Because we have radiology systems and registration systems and lab systems. Not every system is capable of handling some of those elements, and that really can get in the way of the patient experience. But we are seeing, through the evolving of these systems, the greater ability to do things like that for our patients, which I think can make a really meaningful difference. Being able to have gender identity linked to bed assignment, right? That is something we can do, you know, so that patients are placed in the correct beds if they're admitted. So I think there's elements to the patient experience that are coming with those interoperability pieces. We're also seeing that we're getting data being able to come in discrete fields instead of that messy document that I talked about before, to be able to allow for more meaningful, you know, discussions with patients. Patients can go into their portal and select their chosen name or their pronouns, or the information that they feel is important for their provider to know about, and have that information conveyed, you know, that way. The other part, I think the other possibility with interoperability, with the accessibility, is that patients can message their doctors directly, right? You're not going to sit on hold and be transferred somewhere and all of this other stuff. There is an increased accessibility, which I think some providers can find challenging at times, but there is a higher level of customer service that's expected in the marketplace as a result of this openness.
Yeah, very true. So we're coming down to the last few minutes. I want to do a lightning round with all the panelists. The question is, what does interoperability mean to you? But I'm going to put a little spin on it. Is, what does interoperability mean to you as a patient? And what does interoperability mean to you as in the position that you hold? And it might be the same answer, but based on our expertise, it's probably worded a little differently. So Julia, I'm going to start with you.
Okay, so what interoperability, first of all, mean to my business? I think behavioral health is so underrated area of overall whole person health. I mean, come on, anybody knows someone is struggling with some issues, right? So I really take this as a mission, you know, for our behavioral health, especially our community behavioral health organization, to take interoperability, utilize this information driven and utilize advanced technology to provide easy, accessible, and with dissects, with population health, with, you know, try to reduce the SDOH to make a difference to the community, overall health of the whole community, knowing that behavioral health member is getting younger and younger is very concerning. This is our future of the nation, of the world. So I think the mission for us is extremely important, and I want interoperability to play a significant role on how we can serve our member better in the work we're doing. As far as for myself, I hope interoperability growing in the future can be simple, can be easier, and can be fast, can be more accurate, as well as secure. So we can feel comfortable, and also we can feel very confident when we are in wherever we are. Now we're remote working, digital nomads, travel a lot. So these healthcare can be provided to not where the doctors are, but where patients are.
Thank you, Julianne. What you're doing for the people and the providers in Philadelphia is amazing.
Thank you.
Arvin, what does interoperability mean to you as you're in your business, and what does interoperability mean to you as a patient?
I kind of look at both of those as the same, because as a patient, one of the things that I always want to, when I'm looking for a service provider, is to be able to, have them have information about me from, other places, other locations. A simple example of that is I have a really good PCP that I work with, who's a single shop just by himself, and a really good doctor that I work with. But one of the challenges that I always see is every time I go there, there's that little binder which keeps, increasing in size. And at the same time, I end up working with a lot of specialists within other, health systems, in the New York area. And how do I get this information connected? Because every time I go back or get a test from somewhere else, it's like, hey, that information is not being shared. So ease of use is one part of it. Another is, just as a patient, I think I expect a lot more now, more than what it used to be, because, things weren't possible in the past. When you talk about telehealth, it was like rare that you would do that. Now it's like a mainstream regular thing. And then, even with setting up your appointments or finding the right physicians. So when I look at it from a patient standpoint, it's more about access. It's more about, interacting and getting care, where I want it. And that's where, from a business standpoint, also when I work with the different clients that we support within the provider community, it's like, how do we help them get to that point where they're able to sustain their businesses, keep up with competition, and be able to integrate more, take those initial basic steps, and then look at the other parts, which is refining it and making yourselves a lot more competitive and providing better services and quality of care.
Thank you. And Paul, what does interoperability mean to you as a professional?
Yeah, I mean, interoperability, is technically the ability of computers to talk to each other with understandable data. Take that aside. What I'm looking forward to, interoperability is a chance for data to be part of the partner in how your healthcare is managed. And I see it. What's really happening now is I'm getting a lot of critique about there being too much data. I think we're missing a lot of tools to siphon through this. Dr. Patterson mentioned the voluminous document versus the what essentially is FHIR, looking at discrete data elements, and that's a bit of a problem. So I'm seeing a large surge of products that are working with simplifying the data. But to Julia's, to the behavioral health, mental health side, interoperability, I think there is huge in terms of the wellness. Like, mental health isn't about a diagnosis. Everybody's pre-mental health problem, right? So you're pre-diabetic, you're diabetic, but there's pre-diabetics that have a thing in their record, and there's pre-diabetics before that have to eat better, right? And there's different gradations. And we need better, annual visit type data to people on how not to get the catastrophic mental health events, because quite frankly, we can't afford it. Those disasters are real disasters, not to yourself, but your community, family, and others. And we are seeing a surge in that. What's interesting is a lot of those apps that are popping up, and some of these are diagnostic, clinical, digital apps. They're not medications. They're prescribed apps now. They're not connecting to the networks yet. So they're not even getting the baseline data. They're getting it from interview from the patient. And I think we'll advance a lot in mental health when we start thinking of the background data being important, not just the clinical interview and the like, because we saw the benefits on the physical health side. The old data is often indication of where you are in the future, and that's both behavioral and physical data that you can rely upon. So, I think interoperability is a partner in the provider to patient relationship and provider to provider.
Yeah, I like that. Dr. Patterson, last one here is, what does interoperability mean to you as a professional and as a patient?
Yeah, so obviously to Paul's point, it's the exchange of information, but I have added, as I've stressed today, that the exchange of information needs to be done in a functional and a meaningful way. You know, as a patient, I want to move up that ladder from just getting unqualified data. I want to go above information and knowledge. I want health wisdom, right? I want the health information to be translatable to me in a way that I can take action to improve the quality of my life. I want that data, that wisdom, to be accessible to me and the people who are caring for me in my life, wherever I go. That, I think, is where I want to see things progress. And to Julia's point, I think this isn't often, and I want to stress it, what Julia said, because there's, as a patient, it is an implicit demand for security and privacy. We don't make that explicit. It's not in the definition, but our consumers, our patients expect that. And we've had issues with problem lists, diagnosed things in problems lists going to exchanges. You know, child abuse is a code, and that could go out all over the place. In ways that can be really problematic. Domestic violence codes on patients' charts. You tell that to a provider, they code domestic violence. That goes out all over the place, insurance claims, wherever. What if that gets back to the person who's abusing you? So there are responsibilities with this that I think are kind of implicit in there that we still have to really navigate. On the whole, though, I think we're moving in the right direction.
Yeah, thank you so much. And, you know, I really want to take this moment to appreciate and thank the panelists for really breaking down some complicated subjects here and bringing them to life from the patient experience. I think it's really important that we keep the patient in the heart of everything we do, but really break down some of these things that we talk about always at a high level to like understand the small steps we need to take to make some achievable milestones. So with that, I think we're going to end the panel, and Michael, you can close us out.
Thanks so much, everybody. And thanks so much for attending today. Really appreciate everybody's time. We will put this all together. It has been recorded. We will get this up on our YouTube page and we will get it disseminated. And if there's any questions that folks have that they would like to ask the panelists, feel free to reach out to the HIMSS chapter and we will be happy to get you connected with the panelists here to answer your questions. But thank you, everybody, for your time. And I hope everybody has a great day.
Thank you.
Thank you all. Cheers.
Thank you.
Thanks, guys.
Bye.